really take
Hello.
away significant time.
Yeah, it takes
Sir,
your time,
Hemant,
and once you
I heard
answer, then you're a part of the discussion. Then you can't
Yes,
get out of it.
correct,
So
correct.
after reading that, like what I thought was for my boys, my boys were after me in my hospital. So please tell me about this 1, 2, 3, 4. So I told
Yeah,
him, let's do one thing. Rather than me taking a lecture, I've got ready-made lectures. I told them your name. So those
okay.
things were there. I just connected my phone uh, and
Yeah.
downloaded them and ran them through. That was an excellent. They were very happy with that. One, two,
Oh,
three,
thanks,
four
thanks, Subal.
lecture series. That was precise
Yeah,
pinpoint, and they knew
yeah.
what to do and what not to do.
Yeah, I'm trying to at least try to distill out the core essence, Subal, because at least from good literature, because
Uh,
there's so much coming out there, it's very hard for us to see what are the
you
real facts that we should adhere to,
you
isn't
should
it?
prepare one on donning and doffing also.
Yeah, yeah. That there's
One.
so many videos here. There
No,
are so many
actually, there are so
videos.
many videos, but certain pitfalls are there in certain videos. But one
Mm-hmm.
proper protocolized donning and doffing video you should prepare,
Mm.
and you should also have one like the Philippine Society came up with the flu OPD questionnaire.
Mm-hmm.
So such kind of things, what people should do as a physician in the
Mm. Mm.
OPD,
Mm.
like what links for non-intensivist.
Mm.
Now your
Mm.
talks are excellent. So one talk
Yeah.
should be that way. I would say okay,
For general people.
for
Mm.
general people, for
Yes.
physicians, or
Yeah.
for ophthalmologists, or for
Yes.
for those ENT people, those who are seeing patients in the OPD,
Correct,
what
correct, correct.
precautions they should take, when they should suspect, and do's and
Mm.
don'ts.
Correct,
That
correct.
way.
Yeah, maybe I should do. It's
Yeah,
just that, we are amidst working and administrative and
yeah.
preparing. Yeah, but we should somehow,
Yeah,
we should.
no, that's I think that.
actually, regarding donning and doffing, what we have done, because we are supplied with certain PPs from our state government and certain we are purchasing. So I told our infection control nurse to make a video of herself, okay, or
Mm.
someone donning and doffing, so that it becomes realistic. Because
Yeah.
the videos that I'm getting on the net, they are taking up a lot of things.
Mm.
See, and there is again another difference also. Like certain things after the during the doffing, again we see that you are supposed to have the hypochlorite wash also after the end.
Yes, yes,
Yes,
Not
yes.
all videos have it. Like the
Mm.
one which even ISCCM has put it up just now, which Rahul
Mm.
has done, that is not
Mm.
showing that.
No, in fact, Subal, I was thinking after doffing, no, they should have a shower here
No,
and then
no.
go home.
What they say is, no, what they have recommended is once they come out,
Mm.
then before doffing they spray 1% or 2% hypochlorite wash below the neck on both the
Okay.
sides, front and back.
Mm-hmm.
Then they wait for 5 minutes, allow that hypochlorite to dry. Then they
Mm-hmm.
doff out, and after they
Okay.
doff out, they immediately enter the bathroom. They have a
Yes.
shower,
Yes.
and they are supposed to
okay.
get a separate set of clothes
Yeah.
for wearing, and then they get out of the hospital and then go
Hmm.
home.
I think that sounds reasonable. Shower, because I've been telling my
Yeah,
hospital to have a shower. Because right
yeah,
now my two doctors are stationed within the hospital, and
yeah.
when they doff, they should have a shower before they go to the room they have assigned
Right.
to, isn't
Yeah.
it?
In fact, my hospital says we don't have, fortunately, but my
Hmm.
hospital we say that before entering and after coming out, before and after, you have to have a
Hmm.
shower and then only go.
Yeah, yeah.
Have a
Yes.
shower, then
Yes.
dawn, you go
Yes.
inside, come out, doff, shower, and out.
Yes.
We are not doing the hypochlorite spray.
Hmm.
I was speaking with Dr. Govil. He said he was not doing, but that day
Mm-hmm.
I was speaking with Srinivas. Srinivas said that in his ICU they are
Uh-huh.
having a 2% hypochlorite sprayed below the neck on both the sides, front and back, before
Okay.
doffing.
Okay. But does he have any COVID?
So that
Does Srinivas has any COVID
he
cases?
had certain positive patients. Yeah, I think he had one positive. I think
Okay, okay.
one positive. We had about 10 suspects. All of them were negative.
Hmm. We have
Now
right
the
now
major
three positives,
first
Subal.
what? Okay, but
Three positive,
you
but
need
not,
to see.
they're stable in the ward, so they
Okay,
didn't have to come to ICU. One was meant to come, but I think we averted in the ward only.
okay,
But 10, at least 5 to 6 suspects, really sick ones, all came negative.
okay. Now the discussion, actually speaking, if you see, has moved little bit from COVID to
Hmm.
mechanical ventilators,
Yes.
the structural part of it.
Yeah.
Lot of people have come out with ventilators which are indigenously made and which have
Hmm.
got certain limitations, and
Yes.
they are trying to
Hmm.
make the government happy by selling it at a very dirt cheap price.
Maybe you should make a comment in today's webinar, but these ventilators are not suitable
For
for
ICU. Yeah, they
getting-
are not ICU
because-
ventilators.
Because the mortality is so high in
Yeah.
intubated patients with good ventilators.
Yeah.
So
I
let
think-
alone with
So therefore, I thought what you said is right. I was going to say at this point we should discuss it in today's
yes,
webinar.
yes. Make some
The-
points. What I mean,
Yeah.
Nitin sir may be moderating.
Yeah.
So maybe you can come out whenever he
Yeah.
directs a question on anything we think is
Right.
important.
Yeah.
I think Yashbhai, I can see. I don't know if he's able to hear us.
Yeah, I can see you. Hi.
Ah, yes.
Hi, Haribol, Yashbhai,
How are
Haribol.
you? Haribol. How is your wife?
Yeah,
is
good. Yes, Rajesh Mishra spoke to you.
What
Yeah,
happened?
yeah.
What happened?
Hello.
Yeah. Hi, Yashbhai. Both you are in a very dark situation.
I was just sleeping in such a deep sleep. इन्होंने फोन करके देखा है मुझे.
Rajesh keeps everyone in the dark. When he comes, it just brightens up the whole thing.
अब तो bright हो गया राजेश.
Ah.
I just got up, not getting enough sleep. इतने सारे वेबिनार हो रहे हैं. इधर लग इनका कोरोना.
और आप वेबिनार का चैंपियन हो गए आप राजेश.
एक मिनट में बोलो जो बोला है मुझे मसाला चाय पिला दो फटाफट.
It's like it has become बाकियों के लिए कोरोना ने बंद किया हुआ, हमारे लिए तो कोई फर्क नहीं. रोज
जल्दी बोलो यार, जल्दी बोलो.
Sir, how many webinars you are doing today, nowadays per day? It's like it has become बाकियों के लिए कोरोना ने बंद किया हुआ, हमारे लिए तो कोई फर्क नहीं.
Good evening, sir. Mehta sir, good evening.
Hello.
Good evening, Suman.
Good evening.
मैंने बोला मेहता सर अभी कितना वेबिनार होने लगा है, तो सोने नहीं दे रहे हैं.
I've just finished one, yaar. I got up.
But
डेढ़ घंटे से लगा हुआ हूँ. I just got up.
Hello sir. Hello.
और अभी तो इसके अलावा पब्लिक वेबिनार इतने होने लगी. पब्लिक को भी एजुकेट करो वेबिनार पे. It has become
Anyway, Rajesh, that went off quite well. That one which you conducted.
yeah. So thank you. It was,
Doctor, the YouTube live streaming and here also attendees have started to come.
Hmm.
Just wanted to inform you.
Are we ready to start or?
We can.
starting in 5 minutes.
Alkem team. Sandeep sir, we are waiting for Sandeep sir from Alkem.
Okay.
I can't see any of the Alkem on the screen.
They are there, sir. Dr. Hemant is there.
Okay.
How are things in your hospital, sir, now? The Italians?
Italians, 13 have gone home back to
Okay.
Italy.
Okay.
One is still on a ventilator.
Okay. He's still here.
She's 78-year-old. I don't think
Okay.
she's going for a very long time.
Okay, but she's still in the Medanta.
Yeah.
But now she's negative or what?
She is negative.
She's
but,
negative.
On ventilator.
On ventilator. Okay. But ARDS or fibrotic stage?
Yeah, no, maybe must be fibrotic. See, I did a CT earlier, but just now I'm not repeating it because it really doesn't change
It's not started.
very much.
It will start now. It will start now.
Good evening.
The big boss is here.
Good evening. Good evening.
Good evening.
Good evening.
Yeah.
Good evening, Sandeep ji.
Good evening. Good evening.
How are you?
Fine. Fine.
All set? Yes.
Yeah. Dr. Chirag, you are there in the line?
He was here some time back.
No, sir, he's not there.
Okay. Dr. Akhilesh Sharma has came into the line. Our
He was also there. He was also Dr. Chirag is here.
One more topic
Okay,
which
okay.
will be coming up to discussion in coming few days will be the psychosocial impact and economic impact of the lockdown. That should be the new agenda we should be ready.
We are not experts in that, Rajesh.
But people are asking,
No, no.
people are
Rajesh.
asking that also. कि डॉक्टर साहब इसके ऊपर बोलो. हमने
Rajesh is an expert in that, and he's the next finance minister from Ahmedabad.
We'll support him.
People have started asking that also. कि our Rotary Club has asked, sir, इसका क्या होगा? हमने कहा भैया दोनों की जानकारी zero है हमें.
क्या बात कर रहा है
Economic impact on the private practitioners.
Our hospital, sir, our hospital came out with a notification that for the next 3 months they will pay only half the salary, and then they will make it up after 3 months.
Oh, that's not fair, Subal.
Half is not bad, but half is okay. Half is still not bad. People are saying what you earn, you get that only. Hospitals are saying whatever you earn, you get that only.
They said that the deficit will they're given some financial year some different date now. They've changed some date na.
June.
So some date they have changed. June.
They moved it to June.
So till that time they will cover everything. This month they said ki next 3 months we'll give half, and then they'll start covering it up and complete it till like June end financial year.
So you can have dal and chawal, but no tadka on the dal.
Yeah. Yeah, I agree, sir. Absolutely.
Dr. Chirag, you are there in the line?
I think we can start now. Sandeep is
Yeah, we should.
Yeah, that is why. Binay. Hello.
And Dr. Akhilesh is also there now. Sandeep.
Okay. Binay. Hello. Binay is not responding. Binay?
Here, sir. I'm here.
Yeah, Binay, the people have started coming into the line.
Yes, sir.
Can you see that? How many?
Yes, they are there. 120 already there, sir.
So we can start, no?
Yeah.
So
120
Binay,
people there, sir.
So you can connect. We will start now.
Yes, we can start. We can start, sir.
Yeah. So I will start with the introduction and then, welcoming, and then Dr. Akhilesh Sharma will introduce Dr. Mehta, and then Dr. Mehta will take care.
Okay, sir.
Yeah. Once you start, tell me.
Sure, it's ready, sir. We can start.
Okay. Done.
Okay.
Good evening. I will take the privilege on behalf of Alkem to welcome to all our eminent chair, speakers, and panelists. At the same time, my hearty welcomes to all the attendees, doctors who have taken their time out to attend this webinar, and all of you are welcome in this CRITIQUEST. And we have a huge respect and we salute all the medical fraternities for their contribution in this crisis moment in the country. And next one hour, I believe it will be a knowledge dissemination program which we have started, and it will be definitely beneficial for you. With that, I will introduce our Chief Medical Officer and President, Medical Affairs Global Alkem, Dr. Akhilesh Sharma, who is there in the line with us. Dr. Akhilesh, can you just take hand over and then proceed?
Yeah, thanks, Sandeep, and wish everybody a very pleasant evening. And thank you for joining the webinar today. And we are all privileged to have with us an expert panel who would address us today on the burning issue, as we all know today, especially the COVID-19, and nobody better than the intensivist can really guide us in terms of the whole MHA should take care of themselves during this situation and handling the entire PP during the intensive care while managing the patients today, because there are so many, despite we know a lot of things about the COVID-19, but there are still so many uncertainties about the virus, and including uncertainties about the way you all are dealing with patients in terms of which is a patient who may have a COVID-19 positive status and who may not. So with that, without staying between you and the expert panelist, I have the privilege and honor of introducing our chairperson today, who would be navigating and moderating the session, that is Dr. Yatin Mehta. So Dr. Yatin Mehta, actually, I'm sure you all know him and he doesn't really need an introduction, but I would just speak a little few words about Dr. Mehta. He is one of the earliest graduates from All India Institute of Medical Sciences, and then trained further at AIMS, and then in Nottingham, UK, Denmark, and Sweden. And he started his cardiac anesthesia at Ascot's Heart Institute and has been one of the pioneers in cardiac anesthesia and critical care. He has been the past president of the Indian Association of Cardiovascular Thoracic Anesthesiologists and a founder editor of the Annals of Cardiac Anesthesia. He has been awarded with FRCA London and of course FAMS with the National Academy of Medical Sciences and the FISCCM. He is also the president and of the Indian Society of Critical Care Medicine, the simultaneous Simulation Society of India, that is TSS, and Research Society of Anesthesia and Clinical Pharmacology, that is RSACP. He has edited textbooks, various textbooks, including the Critical Care MCQs in Critical Care and the Atlas for Critical Care. He has, to his credit, more than 270 publications in various international peer-reviewed journals and about 45 chapters which he has authored in the books. He's an examiner for both critical care and cardiac anesthesia of National Board of Examination. So welcome, sir. We are very honored and privileged to have you, and over to you to finally take the proceedings of this webinar, which Alkem really wanted to initiate and bring the whole science to the doctors. Thank you very much.
Thank you very much for the kind introduction, and it's a pleasure to be here. And thank you, Sandeep and Alkem, for organizing this. It is difficult times which all of us are facing. So without much ado, I would like to introduce Dr. Pradeep Rangappa from Columbia Asia Hospital, Chief of Intensive Care Unit there. He is a Vice President of Indian Society of Critical Care Medicine. Is academically very active and a very good friend of mine. So Pradeep is going to give an overview of the status of COVID-19 in India at the moment, how to manage it also, and then I will introduce you the eminent panelists later on. Thank you. Pradeep, over to you.
Yeah, thanks Atin. Thanks Atin for a very good introduction. Thanks so much. You're a good friend of us. So what I'll do in next 20 minutes is for today's session. So I will go through the guidelines that have come from different countries, so that it just gives a good teaser for all the panelists to deliberate, because there are a lot of controversial topics in these guidelines, which has come from WHO, the Chinese, and our Indian guidelines. So I will just give a bit of an overview for all the panelists, so that we can generate a good discussion on these guidelines, because some of the guidelines.
Pradeep, one second. You can change to speaker view. It will look better to others. You can change to speaker view, this format. No?
Okay, I'll just.
Whoever is controlling, Sandeep, whoever is controlling, ask them to change to speaker view. That will look better.
Yeah, Binay, can you just help it?
As soon as Dr. Pradeep starts sharing, it will automatically go, sir.
Yeah, is that okay now?
Yes. Yes.
Yeah. So what I will do in next 20 minutes is just give a overview of all the guidelines that have come. I've gone through the 3 guidelines, the WHO guidelines, which is very important. The reason being because all of us adhere to sort of a WHO as a broad principles. Then I've gone through the Chinese guidelines and I've gone through the Indian guidelines. So I've tried to crystallize the essence out of these and put forth the broader view and see and generate a good discussion over the topics that we will be discussing. So I think this happened in India yesterday. So 5th April 2020, 9 p.m. For 9 minutes. So these are the 3 guidelines I have gone through. So this WHO interim guidance, this is the second guideline that came on 13th March 2020. The Chinese guidelines came around close to a month back, and this All India Institute of Medical Sciences and Government of India guidelines came around 27th March. So it will give a good sort of a overview and a lot of debatable issues that we could deliberate upon. So first we'll talk about the case definition as defined by our ICMR. This is extremely important. So the patients who we should become eligible for the testing is any symptomatic patient who has traveled overseas. So that really qualifies as someone for whom the test has to be done. Symptomatic, what are the symptoms? Mainly the fever or sore throat, short of breath, or cough. So any of these symptoms qualifies as being eligible for getting the test done. So the second group are anyone who is in contact with positive patients. So any patient who is a positive and the close any symptomatic close contact of this patient becomes eligible for getting the test done. Or it could be even asymptomatic high risk individuals who are staying in the same household. So be it elderly people, vulnerable people with comorbid conditions who are staying alongst with these patients who have turned out to be COVID positive, they also become eligible for getting this test done. So this is ICMR guideline at this point of time. And generally the test that is recommended for high risk individuals are at day 5 and day 14. So these are the two tests that are sort of recommended for asymptomatic high risk individuals who are in contact with for RT-PCR positive COVID patients, or any of the symptomatic healthcare personnel. So any of the healthcare personnel who has this become symptomatic or otherwise who is sort of suspicious of having contracted this becomes eligible. Or this is a new one that was added: any of the patients who get admitted to the hospital with acute respiratory failure automatically qualifies. So this obviously we have had multiple debates in our states and across India, because although we send the test, I think we can discuss this in panel. So I know this is again a controversial that any patient with respiratory failure would qualify, but I think the centers which do the test obviously have a lot of hurdles when they embark on doing this test. So when you look at these guidelines really talk a lot. The WHO guideline in specific talks a lot and emphasizes a lot on triaging. So I've just put a layout of how I have triaged in our hospital because we were involved in how to create a triage area. So this is the layout of my ER, which I have created. So this is a screening center. I'll show you the real pictures. I just show you a diagram. So this is a space which is created outside the hospital, outside the emergency, which are the screening areas. So any patient who has a flu symptoms enters this area. And anyone who doesn't fulfill as a patient who would need any screening would directly enter into a separate pathway and enter into the ER area where generally all the care that needs to be given for non-suspects would be given. But any suspects who get screened here, he goes into a separate entrance where there are, it is earmarked with red strips, which means he needs to be confined to that passage, and then goes into the flu area where there is a personnel who is donned and doffed whenever a patient comes, and the sampling would be done there, and whatever due admission process that needs to. So if it is a very stable patient, sampling will be done here and he'll be sent off home. But if a patient needs hospitalization, this is the pathway we have created, that he enters this area where there is earmarked pathway, passage where he enters, and he enters a closed confined space where all due precautions are taken with all the protective equipment, and then samples and further admissions happen. So which means there is a segregation of patients between the COVID suspects and the non-COVID in the ER. So this is how, so whatever document you read, Indian document, WHO or Chinese, there's always at least two-page write-up on how triaging has to be done. And as soon as patient is suspected of flu, I think the first thing that we need to do is put a mask to the patient. So because you minimize the spread of the infection imminently by putting a mask, and the droplets would be significantly minimized. And once a COVID suspicion is made, once you have decided sampling has to be done, then this whole distancing starts, because whatever procedure, whatever has to be done, I think should be a safe distance of at least minimum of 1 meter distance to maintain sort of a distancing and prevent droplet infection. So this is my hospital. As you see, this is the screening. So whatever flow chart I showed you is what I'm showing the real picture. So this is the place where they go. Any of the flu suspects, they go in and they get evaluated there. And if they can go home, sampling will be done here and goes home. But if they need hospital admission, then they enter into this emergency. And I'll show you the next picture. So this is the pathway they enter. So there is a red strip. So which means the trolley even doesn't cross there. So they go there and then they deviate and they enter this area. So this is the flu sort of an area where patient goes and their sampling is done and further admission happens from there. So this is the sort of triaging that we have done. So this is the area where the COVID suspects would go in, get triaged from there as to whether they go to the COVID area in the hospital or whether they go into intensive care area, and so on and so forth. So what are the clinical features that has been described? So 87.9% of them have fever, and 13.9% of the patients have sort of sore throat, and 18.6% of the patients have short of breath. This is the general world statistics, and 67.7% will have cough. So these are general. So pictorially, they can have a lot of non-specific symptoms. 13.6% have headaches, 0.8% can have conjunctival suffusion, 5% can have nasal sort of a congestion. 0.9% have been reported to have hemoptysis. The significant symptom they can have is 38.1% of them can have fatigue. 14.8% of the patients can have severe muscle aches, and 3.7% will have diarrhea. And ARDS, if you see the in all these guidelines, these statistics, whatever I'm articulating, is taken from the guidelines. So ARDS is around 3% is what is quoted as people who develop ARDS. But what is interesting is significant proportion. See, 86% of the patients will have CT abnormalities. So if you have a symptomatic patient, X-ray will pick it up only 59% of the times. But if you have someone with little short of breath and tachypnea, it is desirable to do CT because CT picks up the infiltrates much early. And this has been the pretty much the experience across the world that CT has a better ability to pick up these infiltrates. So they have classified. So I've taken the classification from Chinese and the WHO. So pretty much they're similar, but Chinese have classified severe into critical as well. I'll just take you through. So the mild is where imaging is absolutely normal and symptoms are very mild. They can go self-quarantine and they can be looked after at home. Moderate is where they have ongoing fever and bad cough and ongoing sore throat. And there may be some subtle features of pneumonia on imaging. Severe cases is what I think all our esteemed panelists would be dealing with, where you have patient with tachypnea, where you have a drop in saturation less than 93. So ICMR says, not ICMR, the AIMS, WHO says 94, Chinese say 93, WHO also says 93. So you can pick up this number. So these are all numbers. And PaO2, FiO2 less than 300 qualify as severe cases. And severe cases also mean where there is more than 50% progression in the lung infiltrates, either in CT or in chest X-ray. Within 24 to 48 hours, there has been progression of these lung infiltrates, which has happened more than 50%. So the Chinese guidelines, if you look, I think the WHO stops with severe. The Chinese guidelines looks as a critical cases also. Critical cases is where they've come to ICU, they've got mechanically ventilated, and they may be in shock, plus or minus shock, but they have other organ dysfunction. So, and they once they're ventilated, the Chinese have classified into based on the compliance. So, where the respiratory system compliance is more than 30, or it is more than or equal to 15 with mild to moderate organ dysfunction, or the severest one, the stage 3 or whatever, is respiratory system compliance is less than 50 with multi-organ failure. So, these are the three sort of a classifications Chinese have done once they are intubated based on compliance basically. But I think panelists would be discussing on the compliance issue because there's so much noise based on this compliance happening nowadays. And what are the indications for hospital admission? All guidelines say, I think this is quite archaic or intuitive. I don't think any of us panelists need this sort of a guideline. Anyone who appears very sick, whose blood pressure is a bit low, but I think tachypnea is a very sensitive sign to pick up, to consider, to at least reasonably consider some observation. And saturation less than 93, we don't need a rocket science to say they need admission. But anyone with a tachypnea, you would have a little low threshold to get them admitted. And there are certain high risk for severe disease that has been globally accepted in all these guidelines. Elderly people are vulnerable and they qualify as having severe disease. So possibly your thresholds to admit them would be much lower. Or any patients with comorbids, hypertension, diabetes, or any end organ disease like lung disease, COPD, or liver disease, or kidney disease. Any of these on the background qualify as patients having high risk for progressive worsening. So we'll just look into the world data. So this particular study came on 28th Feb by Chinese authors. So they looked at the statistics if you're interested. So ICU admission 5%, 2% get mechanically ventilated, and death rate was 1.4%. So the composite endpoint was around 6.1%. So this was a study which again came from Chinese group on 15th Feb in Lancet. So where they showed 29% developed ARDS, 12% developed cardiac dysfunction, 12% developed secondary, and ICU 10% needed ICU admission. So these statistics are quite variable across the globe. As you see, earlier stages, the ICU admission was less, but as and when disease progressed, the ICU admission started increasing, and even the death rate. So if you see the first article which came in February that showed sort of less death rate, but then once they come to ICU, the death rate went to double digit, around 15%. So they tried to see what are the predictors for death. Age was definitely an important predictor. So this came in the Lancet article on 9th March. So the age had an odds of 1.1 that was significant. And any patient who has a higher SOFA had a high odds of dying. And this was a very important one. They identified D dimer as a very important predictor and an independent predictor of death. So D dimer had an odds of 18.42, which was very high as indicative of death in patients with COVID. So these three were identified as independent risk factors in this Lancet article by Chinese authors. And they looked at comorbidities. 48% of the severe comorbids, 48% of the patients who needed hospital admission had comorbidities. Hypertension appeared the commonest, and this came again from the Lancet article. 19% had diabetes and 8% had coronary artery disease. And what is, again, this particular sort of a Lancet article is a very good one, which looked at the viral shedding. And the median duration of viral shedding once patient gets affected was 20 days. So which means to say when they get infected with COVID, they continue to shed the virus up to 20 days. And the interquartile range was 17 to 24 days. And the longest duration until which the patients continued to spread virus was 37 days. So at this point of time, I have a patient with COVID who has been shedding virus for more than 12 days, all samples coming positive despite being on HCQ, hydroxychloroquine, because we know that Guaret study from France, which said hydroxychloroquine you give in the dose, that viral shedding stops by day 6. But somehow in the patient we have right now in the ward, shedding continues to happen despite being on HCQ. That's for panelists to discuss later. And 95% of the patients received antibiotics from this Lancet article. 21% of these patients received lopinavir and ritonavir as a treatment, and 32 patients needed mechanical ventilation. So this was a study done in 198 patients. 3 patients needed ECMO. So, but what is disturbing to note from this Lancet article was that 97% of the mechanically ventilated patients died. So this is something which is really alarming for all our intensivists, that once they go to mechanical ventilator, the mortality seems to be very high. Although the data that is coming from Italy and US doesn't show such a high mortality, but still for us, the mortality is at least anywhere beyond 50 to 60% once they go on ventilator. So I think this is an important point that I'm sure will be deliberated extensively during the course of our panel. And some of the complications that COVID patients have had was sepsis, septic shock, ARDS, and heart failure. And the D-dimer and high sensitivity cardiac troponin also was always found to be high in non-survivors, which means to say there's a certain degree of myocardial dysfunction that happens, and that also portends a poor prognostic sign in these COVID patients. And 31% of them had VAP. So this was a study from Lancet. It's a very good study done in 198 patients by Zhou et al., which came in Lancet. So now we'll move into the management of mild cases. I think here there are a lot of controversies, which I think will give a good recipe for panelists to discuss. So I have tried to look through all the guidelines and see what are the common ones that I've taken. So symptomatic treatment is no brainer. You give paracetamol. Cough syrups are recommended by our Indian guidelines, but the Chinese and the WHO guidelines do not really advocate cough syrups. So hydroxychloroquine, I think, is very strongly recommended in our Indian guidelines, and so do the Chinese guidelines. WHO sort of says that yes, chloroquine, there have been multiple studies, larger data is done, it could be considered. They just leave it on the fence. So the hydroxychloroquine 400 mg twice a day or day 1, followed by 200 mg twice a day for 4 days is what is recommended in the guidelines. Our Indian guidelines suggest that we should give vitamin C 500 mg twice a day for 5 days. So we can discuss on all these. And azithromycin is recommended in most of these guidelines, 500 mg. These are all for mild. And Indian guidelines suggest Tamiflu until the test comes positive for COVID, until the test is awaited. So after mild case, obviously you'll initiate treatment and send them home. It is recommended they should not use any public transport to go home. They should go in a vehicle which needs to be sanitized later in an appropriate way, and they should go and self quarantine, because the mild cases don't need hospital admission, and they need to be at home quarantined, and the fever has to be monitored for at least 72 hours. But if fever doesn't come down in 72 hours, they need to review back to the hospital and see. And symptom onset to 7 days, or until two samples are negative 24 hours apart, they need to be quarantined. But I think we all have sort of concluded that 14 days they go for a self quarantine. I think the 14 days is sort of mentioned because 7 days they can still remain asymptomatic, and they can still continue to spread the virus after treatment as well. So 14 days is what we generally consider as a norm. But the 7 days is what I think WHO has said, 7 days. So we can argue on that. But I think in India, we have sort of agreed that 14 days is a home quarantine that they need. So hospitalized cases. So obviously, once they are sicker and they need hospital admission, so they need to be put on oxygen. So all recommendations say they need to be put on 5 liters to maintain saturation more than 94%. But if you are dealing with a patient who has severe acute respiratory infection, what we call it a SARI, then we need to put them straight away on a non-rebreather mask for 10 to 15 liters per minute, so that you don't experiment trying to put them on face mask and then move on. So basically, we have to avoid hypoxia. What they need is possibly oxygen at the initial phase. So you want to maintain saturation more than 93 to 94, and then you can wean the oxygen off as and how situation evolves. And all three guidelines, suggestive, restrictive, fluid resuscitation. So we should not prefer to overload them. I'm sure the panelists would argue on this, because there is a lot of data coming on whether they should be euvolemic, hypovolemic, or maybe little on a volume liberal, because now the new data is emerging that they have more of vascular issues. So we'll talk on this during panel discussions. But restrictive is what all three guidelines have sort of recommended. I'm sure my friend Rajesh Mishra will be now laughing when I showed this NIV, because all three guidelines talk on you could consider NIV as deemed appropriate for a short term to see if they respond. I'm sure all panelists would disagree with this, but I'm just telling what is mentioned in the guidelines with a good mask interface, and they have mentioned helmet mask is desirable. But all of us have to be aware that this NIV trial has to be given in negative pressure with all PPE gear, because the risk of aerosolization. So I won't dwell into this. So if you have HFNC or this NIV, so the all three guidelines does say you could give a small trial. Obviously, you would not persevere in continuing with it if they are struggling. So I leave it at that. I'm sure Rajesh Mishra, all of them, my good friends, will have their opinion on this. And all three guidelines suggest blood cultures have to be sent, and appropriate antibiotics has to be initiated within 1 hour. So even here, time is an essence. So all the guidelines recommend that as soon as possible, antibiotics of whatever you think is appropriate, including community cover antibiotics, has to be administered. Azithromycin is recommended in all three guidelines, and Tamiflu, Indian guidelines strongly recommend that Tamiflu has to be added. So investigations, there's no brainer in this. So routine investigation, which includes CBC, kidney function test, liver functions, ABG is a mandatory. So chest X-ray, HRCT, obviously, I think although guidelines say you have to get imaging, whatever is appropriate. So if patient is tachypneic and who is needing oxygen, our recommendation would be definitely to go for HRCT, because you have 86 or more than 85% ability to pick up the infiltrates. If you only limit to X-ray, you fall that you get down that percentage to 59%. And ECG is also needed. So just to show my good friend, all the panelists, that these are the actual recommendation. I've taken the cut paste. So this is the WHO where they suggest high flow and non-invasive. This is the Indian guidelines which suggest NIV may be considered. This is the Chinese guidelines which says NIV. So I'll leave that for debaters to debate. But I think if you see all the Italian videos or UK videos, I think all the patients are put on this sort of a helmet masks. I think these are the ones which we should be using, but we have difficulty in getting this helmet mask in our country. But if you are contemplating on using NIV, definitely this is the way to go, is what I would think. So close monitoring of vitals, obviously once they get admitted to hospital, it is very important. It is emphasized time and again that every patient who gets admitted with COVID, with some respiratory symptoms, oxygen saturation has to be monitored with a simple pulse oximeter of some sort, because time and again, all panelists would agree later on that their oxygen suddenly dips and they can have sudden episodes of desaturation and their down spirals can be quite rapid. So I think the simplest tool that we can recommend is they need to be continuously monitored on pulse oximeter for oxygen saturation. Chinese guidelines, time and again, they reiterate that every admitted patient, it's very terribly important to monitor the oxygen saturation because they time and again mention that rapid deterioration is the norm and multiple information all of us have read that rapid deterioration is the norm in COVID. So obviously NIV, when you put, you just monitor, observe and see if they're winning. If they don't, I think you have to go ahead and intubate. So obviously when you put them on NIV, you see whether, or HFNC, whether their mental status is improving, whether their comfort is improving or short of breath, and obviously you'll monitor ABG. So intubation, so if any patient where PaO2 F5 is less than 200 and there is some hemodynamic instability, we have to go ahead and intubate. All guidelines uniformly say early intubation. So the norm is don't wait on NIV for very long, even if you're put in. So many of us obviously would agree that NIV may not be the best thing in Indian setting. So, but we'll talk about it. So when you are intubating, I think the key essence is there is an intubation guidelines that has come from Australian group in COVID patients. In COVID, how do we intubate? There is a good article that is come. It is a preprint. I've just gone through it. So extreme vigilance. We should have absolute plan because there's no failure. It is, you have to treat COVID intubation as a difficult to intubate, which means to say be prepared for every eventuality because no one can rush in to help a person who is intubating because there is a huge time lag for someone to dawn and come inside to help you. So it has to be treated as difficult intubation. You have to be absolutely prepared with all the gear, have a ProSeal LMA, and it is suggested you should avoid bag mask, but you pre-oxygenate for 5 minutes. It says 5 minutes, some say 3 to 5 minutes, have a giddle so that your oxygenation. So this is the, they say two-hand vice grip is what. So this picture I have taken from the Australian guidelines. So you keep the mask absolutely firm and prevent absolute air leakage so to prevent. So this is the articles. I urge all the listeners to go through this airway article that's come from Australia. So I don't know if in here we can have so much luxury. So this is called COVID airway. So the suggested people is 4 people to be there when you're intubating because in Australia is always an emphasis. It's a 4% technique, but so there are 2 airway doctors. But I think what I have done in my hospital is that there will be one person who will be intubating. There'll be one outside on a standby who would be sort of who would be ready to don if he needs assistance. And if you see the Australian guidelines, they say outside there should be 2 runners to help if they need in the ante room. So I'm a little unsure whether we can have so much comfort in our country, but this is the guideline that has come from Australian group, and they have described this checklist. You can take this checklist and adopt it to our suitability. So as you see, all the difficult airway set is there, Macintosh, all those stuff is there. And this is the circuit that has come from that article. Basically, you need to have a viral filter between the ET tube and the end-tidal CO2 and then to ventilator. Like you have all the gear, you have all the stillets, bougie, difficult airway, and although this cartoon doesn't show it, so you need to be completely geared up with full PPE before you intubate. So basically the message is any intubation, you have no room for error. So once you go in with the COVID tray and the COVID checklist, you can't ask for more help because you have to be absolutely prepared to intubate because you won't get any help without having all the standby at your disposal. So that is the crux of the thing. So you have to treat it like difficult intubation, have all the gear before you go in and intubate, and because you don't want any more dramas there, or because otherwise you'll be putting other people at risk. No one will come to help if you are in a trouble without adequate preparation. I think that's the message on intubation. So once you have intubated, closed suction is always the way to go. I think this is uniformly recommended in all guidelines. And all guidelines suggest that all the filters and the tubings, ventilated tubings, have to be changed 48 hourly. So that's little hard in our circumstance because of socio-financial issues. So I think we can discuss on this whether we will be able to change these circuits every 48. But definitely HME we could change. So ventilation, I won't go into depth. So these are general principles. Again, all the panelists can argue on these ventilatory strategies. So they suggest a low tidal volume, plateau pressures less than 30. It's a typical ARDS narrative that is given in all the guidelines. PaO2 by FiO2 less than 200. Even WHO guidelines says high PEEP could be considered, but we know PEEP is not helping our patients. And PaO to FiO2 200 to 300, we know high PEEP is not beneficial. Recruitment maneuvers, they say, but routine use is not investigated. All this we can debate in our panel discussion, because the current understanding is it's not behaving like our typical ARDS. But there are two variants, one with low compliance, one with normal compliance. We'll discuss that. Proning is advocated by Italian group because they found the lungs are recruitable.
If we can wind up in a few minutes.
Less than 36 hours. If the patient is not improving and FiO2 is less than 150, if your FiO2 is going more than 60. So early proning is the way to go if you are hitting the roof with low compliance patient, and if you are following all the ARTSNet. So I just want to draw about this particular paper which came from Gattinoni in AJRCC, which is a good sort of observation made by Gattinoni. So this came in 30th March 2020. This is just to give room for the good discussion that should happen. In 16 patients, they looked at how the COVID-19 ARDS behaved. So they found, see, if you look at the compliance, this paper says all the 16 patients, they had a very good compliance. So this is what is something which does not conform to our typical ARDS. And they saw the shunt fraction was very disproportionate to the good compliance they found. And the hypothesis Gattinoni makes is the lung perfusion. So it's basically, this is the high point of our discussion. The whole perfusion is somewhere that is sort of a ventilation perfusion mismatch that is happening. And lung perfusion regulation is something that is lost, is what is hypothesized. And because of hypoxia, there is severe vasoconstriction, and even the autopsy reports are showing there is micro thrombi that develops in all this pulmonary, pulmonary circulation. So again, this is again unfolding a new sort of our understanding of why these patients are becoming hypoxic and why we are treating them as ARDS. So this all leads to a lot of speculation, because unless we start treating our ventilated patients and see what their compliance is doing, I think everything becomes hypothesis. But if you have to subscribe to this, it suggests that yes, their compliance is good. It's not the compliance problem, perfusion problem. I think that is where the whole hypothesis of heparin infusion is coming in, and I will discuss that in panel. So that's the graphical representation where compliance is very good, shunt fraction is very low. And the conclusions Gattinoni makes is the increased intrathoracic negative pressure in spontaneously breathing patients, if you put them on HFNC, leads to self-inflicted lung injury, or SILI, what you say. And so I think this is a very important thing. He says, when you give high PEEP, considering their ARDS, so you have these non-recruitable lungs in COVID patients, where the high PEEP, rather than being any beneficial, is leading to hemodynamic impairment and fluid retention, which may be detrimental for these COVID-19 lungs. So this is a very important message Gattinoni gives in this paper. And if you prone, where compliance is very good, but you are proning this patient, again,
Pradeep, you'll have to wind up soon.
Yeah. So I'm just finishing. So this is the last slide, I think. So the COVID-19 specific tests, so you can do D-dimer, ferritin, LDH, high sensitivity cardiac troponin, and you can give inhalers through MDIs, and steroids is not recommended. Specific therapy, HCQ, and you can give lopinavir, ritonavir is recommended by ICMR, and you have to do this. So I think that's the last slide, Etin. So I'll just take you through the WhatsApp images, and then I'll end my talk. Thank you, Etin. So we can generate discussion from here. Over to you, Etin.
Thank you, Pradeep. Excellent overview of how to diagnose and how to triage and how to manage these patients once they're intubated or not, and what therapies are under consideration. I think, I was told to primarily concentrate on non-medical aspects, administrative aspects of COVID-19, that is ICU preparedness and PPE and how to protect your workers. And Saturday, we had a marathon webinar through ILCCM conducted very efficiently by Rajesh Mishra. It was 3.5 hours marathon webinar, which covered all these aspects in pretty detail. So I will just, I think 5 minutes, I'll allow audience to ask a few questions on these aspects, and then I will switch to what I've been told to take care of. So what are the questions? One of the questions was, what about the role of prophylactic hydroxychloroquine? Anybody from the panelists?
See, prophylactic hydroxychloroquine, currently the ICMR recommends that it should be given only to those persons who are, or healthcare professionals only, healthcare professionals who are being managing or exposed to COVID positive patients, or the relatives who are taking care of a COVID positive patients.
Correct.
So that's the only two indications what they have been given. That is one. No normal person or a normal citizen who is not exposed should take hydroxychloroquine. In short.
Any comment from anybody else on the therapy?
On therapy, in therapy in general?
On hydroxychloroquine. On hydroxychloroquine.
On hydroxychloroquine, sir. No, in general, I think Pradeep has covered it pretty well. What we really need to understand that every stage you need to protect your health care worker or staff.
We'll come to that. That is the second part of the whole.
As far as treatment is concerned, we are focusing on three things right now. That is hydroxychloroquine as a treatment, azithromycin as a part of combination monitoring QTC. We do add all the patient fluvial because we know H1N1 can be a associated infection, and to cover community acquired pneumonia, we do add antibiotics. Right now, if we say that we go with that, apart from other treatment, particularly IL-6 inhibitor, depending upon its interleukin level, we are monitoring, and based on that, we can decide about. So general treatment is done and then care of the patient.
Yeah, see, the antiviral therapies are not that much strongly recommended nowadays. Retinol, lopinavir has not really come out. Even the Chinese randomized trial was not really positive. And remdesivir, there's some hope there. But again, it is too early to say. And there are other therapies now available because what they say now, it is a cytokine storm, which in the second week tilts the balance the wrong way with endocrine perfusion happening and all that. So tocilizumab also studies are on. I'm also conducting one randomized large trial on that. Cytokine adsorbers have been used, zilistatin have been used, but these are all on compassionate ground. So it's not really what has been, what is the standard of therapy. I was just having a webinar before this, and there was a major discussion with some Detroit guys who are Kulkarni, the large, they have treated 1,000 patients. They have 300 and plus patients already in-house. And they have started, what they've realized now is something to think about, that as they say, it's an inflammatory response which directs which way the disease and pathology is heading. They are going for early steroid therapy. And prednisolone, 1 milligram per kilo in divided doses, starting early for 3 to 7 days, they're saying. And he said after they've started using that, their patients, the code blues have significantly reduced. Their patients deteriorating on oxygen therapy has reduced. Their ventilated patients also number has significantly gone down. And he's saying this paper is going to be published very soon. This is the
Sir, two things. Mehta sir, two things. One is the steroid, that is the same dose what you are mentioning, 1 milligram per kg in 24 hours, preferably methylprednisolone. We should give in 2 or 3 dividers because it is inflammation and particularly early fibrosis which is killing this patient. And second thing, I think there is a scope because it's a microthrombi which are very obvious and they are causing the all perfusion related problem. So, I mean, we have to go beyond the dose of prophylaxis and go higher dose for anticoagulant till we understand about this, because here the clot formation is activation of interleukin C and particularly those macrophages, those activation are leading to formation of clots. So those clot formation.
That is true. Also, but one must keep it in mind, DVT prophylaxis is a must.
Yeah.
These patients, most of them are pro-coagulant. Microthrombi and end organ failure is primarily because of that. Obviously, DIC can happen in some terminal cases, but this needs to be taken into consideration. Let me now, I think, go to the second part of a meeting, and I would like to introduce my co-panelists. The senior lead panelists are Subhas Dixit. He is a chief intensivist at Sanjeevani Hospital and past president of ISSCM. Everybody knows him. The other panelist is Rajesh Mishra. He's again, everybody knows him as a consultant intensivist at in Ahmedabad and past general secretary, and he has a very bright future in the ISCCM, I'm sure. Yes. And then we have Yash Javeri. Yash also everyone knows is very active in ISCCM. At the moment he's now in Lucknow. Dr. Subba Reddy is head critical care. Again, Subba everybody knows he's a Apollo Hyderabad.
Subba cannot be seen. Subba cannot be seen. He's not there.
I can't see. He's not there.
Yeah.
Okay. And then Bhaskar Chaudhary is a senior microbiologist in infection control in charge of PLS Hospital in Kolkata. So welcome all of you.
Thank you, sir.
Okay, so from the clinical side, I think we now switch to the administrative side, or from prevention and hospital infectious point of view. So now coming to the ICU preparedness, did any of you, how do you think you get your team ready for this thing happening? We all are getting ready now because the thing is going to explode maybe any day now. So how do you plan and how do you prepare?
Yes, shall I start?
Yeah, yes.
Yeah. I think the first step is risk mitigation. We have to keep our heart together. We have
Now,
to have
if everybody puts their this thing on mute, then the sound is better.
Yeah. We have to mobilize our resources. We have to mobilize our ICU resources. We have to mobilize our human resources. We have to have an intercity network of ICUs. We have to have a plan to convert each area into a potential ICU. We start with small resort bed and gradually increase our capacity. We should be ready to have a place which will take over our spills. It might be another hospital, it might be another center in another hospital. Our supply chain should be preserved. That is again very, very essential.
Dr. Yash, sorry to interrupt. Your voice is a little low, sir. If you could come a little closer to the.
Okay, sure.
Thank you.
Pleasure. Risk mitigation is first. Second is we have to have our manpower trained. We should have other specialties, non-acute care specialties should be roped in, especially for treating patients who are in ward, for counseling. Our electronic interface for interaction should be ready. Our supply chain should be ready. We should be having a plan. Small number of patients, we take a reserve part of our hospital. As the number grows, we should be able to make the whole hospital into an ICU. And we should have a network of ICUs in our each city. Yeah.
Rajesh, how do you build an interpersonal team in this sort of situation?
Thank you, sir. Thanks for this question. In fact, at present, we have to go on certain calculation and presumption. So suppose I start with a 10-bed ICU where I will be taking 10 patients. The first and foremost important thing is you have to remember that each area, right from the ambulance to emergency to entry of the patient till ICU, should be separate. In any hospital, wherever we are managing this patient, it should not be mixed with the common patient. Preferably, I am of the opinion it should be a dedicated COVID hospital to avoid. If it is not, if you are every hospital is taking, segregate everything. That is the first most. Now coming to our ICU preparedness, we need certain level. We know that we will not be able to provide 1:1 care to the patient is not possible also. And simultaneously, we need to have a backup because once staff start duty, they will have a risk of infection. They will have risk to infect their other relative. So the plan starts like that. I will start with 10 or 12 bed ICU. I will go 1:4 or 1:6, maximum 1:4 care for proper nursing staff. That means I have a 12 bed. So I need minimum of 3 nursing staff in one shift. They cannot do more than 6-hour shift because with all those apron on, with all those things on, it's humanly impossible that somebody can wear it for more than 6 hours. So all those staff who are going to do hard work, that means you need at least, even if it's 3, you need at least 12 staff per day. That means at least you need 36 staff to cover all those things. If you want to do it properly, that will be the first. It is nursing staff. Now these are the main staff. You need supporting staff also because one staff taking care of 4 patients is not possible. At least you need 1 or 2 staff to support them. So first thing will be the staff preparation, the numbering, staff number. Once we have got that number ready, maybe I can start with lesser number. Their training how to wear those protective gloves, how to remove those gloves, what they should prepare before entering in those gown and what they should after entering gown. So that will be the second part, will be the training of taking care of themselves. Once they have taken care of themselves, the third stage will be what they should do with patient, what they should not do patient. particularly the most important thing, they should not do any procedure which spills over or which just the secretion should get spread. So they should avoid all kind of procedure. That means patient will be totally locked, closed suction, and not allowing, not too much of, no coughing allowed. All these things they have to be trained with. So number of it up, coming to the doctors. Doctors, at least for 10 bed, you will need a one uh, registrar level of doctor at least to inform you, to give you a backup. Suppose you are going for more ICU bed, maybe you are in charge of the total taking care of ICU, maybe you are having, but at a one time. Now these doctors also cannot wear those gloves, and he can also not be there in those suits for more than 8 hours. So at least you will need 3 doctors in a rotation to give you the backup. That means even if you go for the 7 days on and 7 days off, maybe, but at least you need 6 doctors backup. Why every time we are saying, one has to remember that you cannot have a daily kind of rota, because the moment you go home, very likely you are going to infect your relative, family.
Okay, hello, Subal, can you hear me?
Yeah, so these are the issues which we have to take care of.
Oh, one request to every panelist, just stick to about 2 minutes for each answer so that you can include everybody.
Okay.
Subal, now one quick question to you.
Yes, sir.
Is what sort of stocks you need to have in your possession?
So the stock taking basically is the PPEs, the N95 mask, the normal mask, the gowns, the goggles, and the shoes. That's the main important thing, because the number of PPEs which are really going to be required in the ICU for managing ventilated patients is going to be quite large enough. That day I was just discussing and taking into consideration for a 10-bedded ICU, it may also require approximately about 20 to 30 PPEs per day. So you require a large amount of stock of PPE which should be kept and procured. That's very important. So the stock taking is important. And apart from that, I also need to have a DG machine. All the technicians also should be trained, or even the doctors also should be trained for taking out x-rays in case if required. And along with the crash cart, special laryngoscope if required, a fiber optic disposable laryngoscope also should be considered, and all those stock taking should be taken into consideration and should be maintained.
Yeah, so as little movement of the equipment outside the ICU as possible.
Yes, sir.
So I stationed a portable X-ray machine where you can look at the films also. I have an ultrasound machine inside. I have POCT for PCT, and whatever is required, you kept mostly inside, and things don't come out.
Sir, very simple, that it should be dedicated to that area. I don't take out anything, whatever is needed there. Anything, it's not possible.
Always over calculate your requirement. Because administration will always try to cut it. And there is no question, nobody can work more than 6 hours, in that environment, as Rajesh rightly said.
And sir, one more thing, that at least when you start working, keep at least 7 days stock every time ready, because your stock very fast get over, and then finally you can land up in a situation where you are not having those protective gloves, and then you cannot work. So that situation should not arise. The backup plan should be ready also.
The first principle is, without a proper PPE, do not enter the COVID ICU. That's the first most important thing. You must remember.
Okay, Dr. Chaudhary, I got a quick question to you. That how do you dispose the biomedical waste?
Yes. Actually, the National Biomedical Waste Guidelines, they have the National Pollution Control Board has come up with the guidelines. So this is nothing different from the guidelines that are prevalent, 2016 and 2018 guidelines. Only thing that is that we have everything yellow. Everything goes into yellow now, and double jacketed yellow. Okay. So all the things, even gloves should be disposed in yellow in the COVID ICU. Okay, or COVID ward, which is designated for COVID. That is the only difference that is there. And we have to mark on the, when it goes finally for disposal, we have to properly secure it. And then everything, we have to mark that it's COVID-19 positive. So that's the only difference. Otherwise, the disposal is the same. And in certain cases, we are also being forced to use the surgical gowns in, say, in the suspect areas in the ward, not in ICU. So surgical gowns, we have given a drum containing 1% sodium hypochlorite in that. So the linen also goes into that, in that drum. It's dipped there overnight, and then it goes for washing. So overnight treatment with 1% sodium hypochlorite or bleaching solution is enough to kill the virus.
Yeah.
And once you're...
Can I add, sir?
Yeah.
We have to be very, very particular. Whatever goes in the hot area stays there. Whatever comes out has to be sanitized. And we should be using maximum disposable things. Even bed sheets and patient clothes could be disposable, and avoid recycling those things.
Yes.
Dr. Yatin, your mic is muted, sir.
Mehta sir, your sound is not there.
Yeah. Once your, say, gowns, conventional surgical gowns, not the disposable, but suppose they have gone to the laundry.
Yes.
Do you give PPE to the laundry personnel?
Laundry persons, actually, that's why we are pre-treating them in sodium hypochlorite and sending to the laundry. But basic PPE should be owned by all. So the basic PPE is goggles, mask, at least surgical mask, and gloves. These are the basic PPE. If a gown is available, then wear a gown or apron or plastic apron.
Okay, that brings me to the question of who should get N95 mask, because there is a gross shortage. Not only here, in US, they are reusing the N95 mask. So who should be using N95 masks?
Actually, there are clear-cut guidelines regarding this also. So any aerosol generating procedure, anybody who is conducting any aerosol generating procedure should always wear an N95 mask. And anyone who is in the COVID positive ward, taking care of COVID positive patients for the shifts, say 6-hour or 8-hour shifts, they should wear the N95 masks. So aerosol generating procedure even includes the sample collection and nebulization and bronchoscopy endoscopy, if this is done. And another thing is regarding the dental procedures. They are also aerosol generating. So I have advised, now the dental procedures are being held up because the OPDs are closed in most of the cases. But whenever dental procedures are also, and the ENT surgeons are also at risk. Okay. So these are certain cases. There are other aerosol generating procedures also. So we have to identify those procedures.
Mehta sir, your voice is not audible. Mehta sir, your voice is off. You don't switch off your mic, sir.
What about endoscopy?
Yeah, sir. Endoscopy is again equally dangerous as an endotracheal intubation.
Yeah.
So all due precaution, because we have some case reports from India where upper GI endoscopy was done and the patient got infected. So it has to be done with due vigilance and equal full PP precaution. One word on N95, whenever we are in close contact with suspect or confirmed case, or whenever we are in a closed space like an ambulance or in a closed room like an ICU, we should be wearing N95. For routine interactions, surgical mask is good enough.
So even the intercollegiate association for surgeons have come out with guidelines for surgical patients. That means all emergency surgery should be treated like a COVID, and even endoscopy suites should be taken as a COVID patient, and all the endoscopies have to be compulsorily in PPE. And now they are recommending, as per them, that any emergency surgeries or
how does one get so many PPEs? I mean,
yeah, I know it's very difficult.
Intubation is important. So
for time being, to manage the resources, it should be highly recommended that all the planned procedure, maybe it is upper GI,
should be deferred.
Because right now, if it is not emergency, if it is a planned procedure, they should be deferred for time being.
Yeah. Okay, there is a question.
It can be scopy, it can be anything. If it is not emergency, it should not be done. All the planned procedures.
There is a question from the audience that can you reuse N95 masks?
Yes, I can answer that. Actually,
Yeah,
I asked CDC for a quick solution on this because we have to improvise nowadays. So CDC has come up with certain, one we were already using, the UVGI, the ultraviolet radiation. Although it causes some damage to the structural integrity of the masks, and most of these masks are not reusable, they are disposable. So I have advised, we have formed a UV room. That is the easiest. And there are some other recommendations like hot air oven and these things, but they may cause damage to the rubber band. So UVGI is the best option that is available. And if it is put under UV radiation for half an hour each side, total for 1 hour, then it becomes reusable. But actually for the positive patients, those who are taking of the care of the positive patients, I've asked them to dispose the N95 masks. But this reusable also, you cannot reuse for more than 72 hours if you are using constantly.
See, they say the N95 mask should not be used constantly more than 6 hours.
Yeah.
Actually,
also, some studies have shown in US of it reused safely. Stanford is a Stanford study for 20 times.
For 20 times.
Recently, plasma sterilization has been approved also. You can do plasma sterilization. What we have started doing at our place is that we have a hot air oven, which has also been used. There are published studies on that. 75 degrees for half an hour. So we provide them with a bag with the person's name, and we are saying we use it for 6 times. So they keep a log on it. After 6 times, they throw it and they take another one. Because we'll have to start restricting the proper uses of this. Otherwise, we are going to land up in serious trouble.
Sir, one more thing to save the resources, that there are grade 1 and grade 2 PP. So all those people who are not in direct contact with the patient and aerosol generating procedure, they can be given grade 1 PP, and that will again save the resources. That concept also has to be utilized. One has to think for that also.
No, I absolutely agree with you. The people who are directly working in aerosol generating procedures in these patients obviously should be fully geared. But others can wear grade 1, which is lesser than this, which is probably more comfortable also.
Yeah.
And which should limit resources.
And they can increase their time to 8 hours and more for duty if they want. They can do that. So that will save human resources as well as the material resources.
Yeah, but the PPE, one must remember, every corner tailor is making PPE now. You know. Yeah. So what is the PPE which is required in this thing? It has to be waterproof. And there are other criteria also. But it has to be waterproof in a 2 atmosphere. The water should not go in.
Yeah.
That is what the testing thing. Obviously, we can't test it as that, but waterproofing we must insist on before we start using these PPE. So, also, the glasses. One has to keep it in mind. The glasses which you wear on top of this thing should be having a seal. Today, I was shown a pair of glasses which had some holes for ventilation. They said it's also for ventilation, otherwise it fogs. I said it doesn't serve the purpose. You know, it has to be proper seal.
Yeah.
Pradeep, can you comment on this? What you are saying? Pradeep, can you comment? Pradeep is showing something. Mehta sir, Pradeep is showing something.
Pradeep is coming.
You are not audible, Pradeep. You are not audible. You are not audible. You are breaking.
Yeah, but I can see that.
Yeah. So this is what we have been using it for our the reason is that
Doctor, your voice is there are a lot of disturbance in your voice.
Okay. Now, but what he was showing, I can see that. These are the FFP2 and FFP3 masks, which are quite effective. In fact, in NHS, they are issuing these masks for they can use it for 2 months. And they clean the filter and they can use it for 2 months. So if you can lay your hands on these, do that, because they are probably more effective than N95. And although it's a bit heavier, but it is safer also from that point.
Are these easily available in India, sir? Pradeep, we can't hear you.
Okay, sir.
Are these easily available?
Questions keep on coming. It is not related to what we are discussing. There was one question on ivermectin. What is the role of ivermectin? Well, it has been shown to have antiviral activity in vivo, in vitro, sorry. But in vivo, it has not been shown as yet. There are one study in human which is on compassionate ground, which is going to start. But at the moment, I would not say that it is recommended for human use.
Sir, one question which is very relevant: how to sterilize laryngoscope? Because particularly video laryngoscope and fiber optic laryngoscope need to. Dr. Bhaskar, would like to comment on that? How to sterilize the laryngoscope? A lot of people are asking.
Laryngoscope, I think paracetic acid can be used. Nowadays, orthothaldehyde is not recommended. So paracetic acid is okay for if you dip it, and you do an enzymatic treatment also to remove the protein fibers, and then paracetic acid or anything like that.
Okay. Sir, Mehta sir, to you.
Yeah, otherwise, see, if you're not using a sophisticated laryngoscope, which just gives you a direct visualization, the regular laryngoscope has plastic plates which are disposable.
Yeah.
And now they're not that expensive. They cost about $150 or something like that. So we might as well use that disposable plate and throw them away.
But suppose video laryngoscope, they are
that you'll have to sterilize.
Yeah, that's what the thing is.
Or,
one has to be very
Dr.
careful.
Bhaskar, if you dip it in for 30 minutes in Sidex, is that okay?
Sidex OPA. Actually, Sidex OPA was recommended earlier. Now we are going for paracetic acid. Sidex OPA is also good, but there are certain issues regarding that. That's why we are doing away with Sidex OPA. So paracetic acid is safe.
How do you manage a PPE breach? Nurse comes to you and says, sorry, sir, my mask came off when I was doing suction. Any of you can answer.
Sir, this is a very difficult question because most of the staff whom we are going to take, we are already on hydroxychloroquine. We can only train them and reinforce they should not happen. If it happens up to maximum under QTC monitoring, you can keep under observation, keep them under full quarantine, treat them with hydroxychloroquine and azithromycin in combination, and hope and pray that they should not get infected. But I think again, for education, and education will do the purpose. But it happens, you need to send them in quarantine, complete quarantine.
Yeah, first you need to de-roster her from duty also.
Yeah, that's why I'm saying you you need to send her quarantine and treat her.
And how long to quarantine? See, class
14 days.
Traditionally, you should quarantine them for 14 days.
14 days. 14 days.
No, sir,
if you start putting everybody in quarantine,
no.
You've been exposed to these people.
Almost all the hospital people where the people have been there, they have been quarantined for 14 days.
Sir,
in Maharashtra.
Subal, to make keep your human resources ready, I personally feel that it is like that a lot of people are doing in US and other place. What I have learned from them, that you start treatment. If they do not show any sign up to 7 days, you can test 2 tests. If 2 tests are negative, probably your patient is negative. If 2 tests 24 hours apart, properly sample taken, particularly the nasopharyngeal, if they are negative, then they are negative. If they are showing any signs and symptoms, I'm talking about particularly if there is a breach in PP. I'm not talking about the routine case. If there is a breach in PP and they're suspect, but there is no signs and symptoms, first 5 to 7 days, and 2 samples has been negative, probably after 7 days you can take on work.
Yeah, and sir, one thing, Mehta sir, one thing, and before we would ensure as a that the donning buddy should check the leak test for the PPE before N95, before he or she enters into the ICU. That's the most important first thing.
See, these are very, very good things to say, and there's no problem with that. But ideally, for N95 mask, you have a leak test machine available.
Yeah, I know.
How many of us have that?
We don't have it.
Nobody has that.
We are just using a simple leak test by doing
that's okay.
the breath test. That's all.
That's okay. It's worth doing it. And how do you train them to do that? I think we all should have a training thing for everybody.
Therefore, they say that
I myself didn't know how to don till we saw these movie films, and then you have to show them, and then you show live. First you show them the movies, and then you show them live how to don and how to doff.
So therefore, they have suggested you should have a donning and a test buddy to be helping.
Yeah, somebody should be observing and helping. Yeah, absolutely.
Yes. Yeah, Pradeep. Yes, Pradeep.
Pradeep, there is some problem in noise. I think you need to log off and then log in again. It's completely breaking. We cannot hear you.
Can't hear anything.
Sir, the doffing area should be large enough. We should not contaminate the area where we are doffing. It is good that somebody is observing us in the donning and doffing phase. Otherwise, it is good to have a mirror at least in the donning area.
Yeah.
And now, although it looks theoretical, but people are also saying if you are too much scared while you are doffing, you can have a camera recording doing. So
you can have a camera recording doing. Secondly, you should also have a below neck.
If somebody is not watching
yeah,
it.
at
But
the
it
time
looks
of talk.
impractical for us. But people
Yeah.
are doing that also.
Yeah.
If it's practically possible and there's a camera recording,
Yeah.
and if you have doubt that you have not done it properly, what is the most important thing of doffing is that now in each stage, after removing everything, you need to wash your hand. After removing shoe cover, then you remove when you remove your
Every
gown
step,
and mask,
yeah.
every step you wash your hand and touch other thing, because the moment you have touched the thing, you have infected your hand, and next time whatever you are going to touch, it's going to infect. So
Yeah.
initially it was there that 1 or 2 times they were washing hand. Now
See,
after
there,
each doffing procedure, you have to wash.
Rajesh,
There are
one
a
thing is
lot
that
of-
even before doffing, they have suggested you should give a 2% wash with hypochlorite before on the front and back below the neck.
Yeah.
And then you should, after 5 minutes, then start doffing.
As you come out of the hot area, you should have a flush with this. And if you are in doubt, wear a fresh glove over the old glove.
Yeah.
Then restart.
Right.
and we generally, once we doff and come out, we have a shower before we.
Yeah,
and
you
then
have
we
to.
change it. Yeah.
You should have a doff, then shower, and then change into a new set of
New
clothes, and then go.
Yeah.
Sir, one very important question coming. I think we should address it. What precaution when the staff goes to home? Anybody wants to take that? What precaution you would give your staff to take when they go home? Anybody answer?
Sorry?
Should
What
ideally it should be like a home
when you go
quarantine.
home? When you go home,
He or she should be under a home quarantine. Ideally, if you see certain hospitals say that they should not go home, the hospital is making arrangements for them to stay for about 10 to
lot of voice crack.
Hospitals are not having those facilities. Those people should stay in the house, but separately away from. You should not be staying away. You should be staying separately in your house separately. It should be like a house quarantine completely.
Most of the hospitals have taken over hotels which are nearby.
Yeah.
And they are staying. Or at house, you have a separate room away from the main living rooms. You stay. People in US are now staying in a tent in the garages also. They have gone to that extent. And if you have old parents or at risk individuals at home, then avoid going home till you are doing your duties.
Okay, there is a question from the audience about what about if you got pets at home? What does one do with the pets?
Well, a tiger has just turned out positive today.
Today in the zoo of New York City, one
Yeah.
tiger has been found
positive.
So I believe you have to quarantine your pet also when you suspect yourself. Right now we can think like that only. Don't come in contact with the pet.
You have to take your
there are special N95 masks which are available for pets. That's very important.
The most dangerous thing for pets is their paws get contaminated. So whenever they come in from outside, you have to clean their paws, or you have a cover for their paws.
Am I audible, Rajesh, now?
Yeah, now you are.
Yeah, you're audible.
Yeah, just I have a quick comment. See, we had a serious argument with my radiology department in my hospital regarding sending COVID patients for CT here.
Yeah.
Because they had a serious objection saying that when we get a COVID, I think we have a lot of issues in sanitizing the whole environment. So I had this question for you, Yatin sir, or whoever is doing CTs.
Yes.
How did you circumvent this? I'll tell you what we did at the end. Then after I hear from you.
May I? Yeah. May I?
Yeah.
We have to avoid CTs. If there is obvious abnormality in chest X-ray, we don't go for CTs. If
we have abnormality, we have high index of suspicion. That's why we are doing it.
If the diagnosis is clear and pre-test probability is high, we can avoid CT. CT has to be done if your clinical picture is not correlating or your X-ray is not revealing anything. Then you go on for CT. And second, in big hospitals, it is a good idea to have a dedicated machine for COVID patients as we go to it.
See, it is easier said than done. See, we did have a CT for the first few patients when we were not certain of certain things, or we did it in the middle of the night. I mean, when other people were not. But otherwise, it's difficult to do CTs for every patient, and it's not recommended if you know unless it affects your therapy.
Yeah,
for establishment. Agreed that the CT scan has a high sensitivity along with the clinical signs of diagnosing the disease. but I don't think we should use it for diagnosis.
Sir, my dictum
Ideally,
is,
we should avoid it as much as possible.
my
Because it's not
dictum
going
is,
to change the treatment plan per se.
my dictum will be,
I'll tell you the
I am not a COVID hospital, that my hospital total is COVID. It's a different scenario. Otherwise, you should not be contaminating other sterile area. When you are going, you cannot do. The ACT, if it is not going to change your treatment, you avoid doing it.
Yeah, it should not be done just for diagnosis.
Yeah.
There is one question from the audience that how do you clean the ventilator between patients?
I'll take it, sir.
What should we do?
We should be using viral filters first at the expiratory ports. And the expiratory cassette has to be changed from patient to patient. This is possible till the time we don't have a bulk of patients. But when we have a bulk of patients, it will be very difficult to change it every now and then. Otherwise, it should be changed from patient to patient. It should be cleaned thoroughly and goes to CSSD. And then we put a fresh expiratory cassette.
Yeah.
Okay.
Sir, since we are here on to ventilators, I would like to just discuss one thing, which is currently now overall the discussion all over the country. Certain industrial people now have started coming in with indigenous made ventilators. You must be aware of it. So I personally would like to discuss this point here. So what is your opinion? I've got limitations because these indigenous ventilators cannot be compared with ICU ventilators because there are plenty of limitations into this. As far as the use of circuits is concerned, as far as the delivery of FiO2 is concerned, as far as the application of PEEP is concerned, and certain circuits are only, they are very, means a particular kind of circuit can be used only with that particular ventilator. And you cannot use high PEEP. So technically the amount of ARDS, the COVID patients are having ARDS, even if they have got a low compliance.
Is not going to require high PEEP or high FiO2.
Yeah.
Can I get a question?
Secondly, can you guys hear me? Yeah.
Yes, sir. So
every patient is not going to require high PEEP or high FiO2. Also, at this point of time, buying high-end ventilators and a large number of this may be difficult financially. I think one has to be reasonable. For patients who require more sophisticated ventilation, you reserve these ventilators. Otherwise, you can make do for many of these patients without really very sophisticated ventilators, where I've just tested a few Indian makes.
No, therefore I wanted your opinion on that.
Let's not waste too much of energy on inventing ventilators. There are some companies who are trying to invent ventilators at this stage, make new ones. You can't do that. I mean, it's such a short notice. I mean, it's a sophisticated equipment which you can't invent. You already have the wherewithal to manufacture. That's a different thing.
One small comment here. See, when we require, these are not ventilators in true sense. They are just compressors of ambu bag. So it will be a very, very, very desperate situation where we'll be forced to use it. We are not going to use in a normal circumstance. See, now, US, they are intubating 40,000 patients daily. They are short of ventilators. So we are not far away. The day will come. And we have learned from previous epidemics while they were resuscitated with an ambu bag. So,
So I was discussing with a friend in New York who's working in the ICU there. And many of the elderly patients, who have comorbidities, they won't even put on ventilators because they are short of ventilators. Also, even if they are on ventilator, they're not getting any better in a few days' time. They'll just take out the ventilator after talking to them.
So these are the patients who can be shifted over to such.
So correct. I would think that you may have this thing as a step down or while you are waiting. That also brings me to a lot of discussion is going on, particularly among the non-intensivists, about ventilating 2, 3, 4 patients with the same ventilator.
That is absolutely wrong, sir. That is wrong. I mean, that's even the American Association of Critical Care and the Thoracic Association have already released the guidelines.
Yeah, they have released that
they should not be using.
But there are multiple people.
Because of chances of development of villi or all these problems, the delivery of PEEP, tidal volume, everything is going to be different.
One question is, should we avoid nebulization? Yes.
Absolutely.
Yes.
Yes. And if you have to use it, then
metered dose.
Anything which breach the circuit, should not be done. Any procedure. And nebulizer is not going to help. We should just put it like that. Nebulizer is not going to help you anyway. What will help you? And first thing is our safety is important. So do not indulge in any procedure which jeopardize your safety. Be very careful. So no.
So closed suction catheter, don't disconnect the ventilator. Even if they say, even when you turn the patient, you don't have to disconnect the ventilator.
And if you have to
when
disconnect,
you intubate, you inflate the cuff first. Then when you connect the ventilator, after you are sure there is no leak, I mean there is a cuff is inflated, and only then you connect the ventilator. So these are the things
sir, here the concept of blocking the tube, they were clamping, but I will say you put
correct.
a filter
Once
over
done,
there.
you block the
You
tube.
can put a filter. You can put a filter and then intubate. So even patient, some secretion comes out that you don't get it can spill over on you. Yeah. So they're important.
See, Mr. Modi has announced 50 lakh of insurance for medical personnel who are treating this COVID-19 patients. But let me assure you, all of you, that this insurance is not for people working in the private medical field. It is only for government medical.
You have to take care of yourself. You have to take care of yourself, not for, and your safety is most important. Whatever you do, keep yourself safe. That is the most important thing.
Also,
I have two comments to make, two questions rather.
Yeah.
So as per the guideline, it is suggested that we need to change the ventilator tubings every 48 hourly. So that would it be feasible in our country? That's one question. The second one is the Singapore data is telling us there is a lot of tube blockages that are happening with HME filters vis-a-vis heated humidifiers. So would our practice change? Because there have been a lot of reports coming from Singapore practitioners saying there's a lot of extensive tube blockages that is portending threat for these patients. So any of the panelists, you can comment on this.
I will take
that recommendation is there about heated humidifiers, but I don't think, see, most of us have gone away from heated humidifiers. How many heated humidifiers you'll have in your ICU? I mean, because of, again, the risk of cross-contamination and chances of VAP. So if you have it, sure, it is theoretically a better thing to have. But again, chances of leaks and all that is much higher than this. HME is a much cleaner, less contaminating procedure. And I generally have not seen really too much of blockages of the tubes. And
Sir, the first question, Dr. Rangappa,
yeah.
No routine circuit change should be done.
Yeah.
We should not go on for routine
change. I think it's not cost.
Pradeep, that recommendation is for every circuit. They recommend for disposable for everybody. So I mean that we need to be indigenous. What we are seeing with the circuit, we do not need to change. What is the reason behind that? Is there any rationale for doing that? Is there any rationale? Is there a rationale for that?
They are not given rationale. So I was just reasoning it out. Why this recommendation came from the.
No, I don't think
even for filter, 48 hours, if it is working well, it's not swell, it's not getting blocked. You continue with up to 48 hours. I don't think any reason to do that. But you have to be careful. It should not get blocked.
Yeah. I agree, Rajesh. Good.
One more point. The suction jar, we don't discard it. It is again a very, very dangerous procedure from infection control point of view. So you have to have indigenous covers for suction jar, which are leak proof. Do not just go and discard these secretions into the sink. You have to have a suction jar and then it goes into the yellow bag. Be very careful with the suction jar.
Sir, few of them are asking ventilator setting. Can somebody take on that? What ventilator setting to be initiated to begin with? There's some question on ventilator setting. And then one more important thing we need to address that if we are combining chloroquine and azithromycin in combination, and if patient has borderline QTC high, what should be done? It should be given, not given. If we are given, what precaution?
See, I had a doctor patient who had QTC prolongation. I did not give it. I gave antiviral.
Yeah, no, Yatin sir, we had a patient who was on hydroxychloroquine and azithromycin with diarrhea with hypokalemia. He had a QT prolongation, but we corrected potassium, magnesium, and then we just continued. I think it settled. We were monitoring it though. So I think as long as we are monitoring, I think we are okay and not allow it to go to the toxic levels. Yeah.
Azithromycin is given for 3 days only. Am I correct?
No.
How long you are continuing with azithromycin?
5 days.
This is what is recommended.
5 days and plus azithromycin has got a post-antibiotic effect for 7 days.
Sir, ventilator setting. Somebody should discuss ventilator setting because a lot of people are asking about it.
Okay, there was one question about if a patient was suspected COVID is a term PCR negative.
Yes, that's coming.
I was just going to. How do you handle it?
Negative.
Actually, the first test, maybe if you only send a nasopharyngeal swab, there is a chance of false negativity. Okay, if it is early in the infection. So to increase the yield, we are recommending both a nasopharyngeal swab as well as a throat swab to be dipped in the same viral transport media and sending for PCR. So the chance of yield is around 93% if you put two samples together. So if it comes negative, then you can take it as negative. And another question I was
no, Dr. Bhaskar, one negative sample we should not take negative because
two negative samples. Is it?
Two negative
at least
In
samples.
a suspected case? I don't know.
Yeah.
Oh, that is if the first sample is positive, then every two to 4 days you have to keep on repeating samples. Okay, till the two consecutive samples is negative, then you can declare the patient as free from COVID.
No, if there are two negative.
But if you
two consecutive.
Even for suspected. Even for suspected. Or there's no confirmed case.
Sir, even for suspected, even two negative, and you think the lung is behaving like COVID, still it can be positive because this virus attack your AC receptor. And there is a high likely that even in nasopharynx and even upper respiratory tract, it can be negative and still your patient is positive. If you suspect, you keep on managing like COVID till you get lower respiratory secretion or till he become asymptomatic. Don't leave it. There are chances where there are report cases where fourth or fifth sample has come positive when it was taken from lower respiratory tract.
Okay.
The dictum, sir, here comes the dictum. If you think it's COVID, you have to treat as COVID. The positivity normally is 70%. And the way we are sending samples, the turnaround time is 2 days. It goes to other city. We don't know the cold chain is maintained or not. So if you think it is COVID, it is COVID. Treat as per COVID. And the infection control measures have to be like COVID. More important.
See, every patient with respiratory symptoms coming at this point of time is a suspect. Travel history and all has gone out of the window now.
Yes.
Now we had a question also. I think after that we should now conclude because it's getting on. That if a patient, what does one do for patients who are coming for surgery? So I have just today decided to all the elective surgeries or surgeries planned, not semi-elective, whatever cancer surgeries, I have said do an RT-PCR of all the patients pre-operative, which some of the other hospitals also started practicing. So at least that gives you some degree of safety.
Sir, I think I was discussing with Subal just before this started. It's become a problem in my hospital because some of the surgeons have started doing elective stuff and bringing them to our ICU. And that is portends a risk for us. So in fact, I've been telling my admin to not do these elective cases. So this is an administrative issue. So it is a tussle between surgical team and us and the thought process, So
But Dr. Rangappa, this is a very, very serious issue. We should not take this issue lightly. Why? They are wasting PPEs, they are wasting resources, ICU will be occupied, and the risk of nosocomial COVID to those patients is huge. So this should not be allowed at all. And for emergency procedures and for emergency surgeries, there are guidelines. We have to wear double mask, double glove.
You do that.
Yeah. So
in fact, some people have made a COVID theater.
Yeah.
The separate theater where the high-risk COVID patients are operated with all the precautions. But
I must tell you again and again. The only thing which will save all of us.
Okay, I think we had a good discussion.
Sir, one question is, sir,
and I would thank all my panelists.
Sir, ICMR, sir, just one question, sir. One question. So ICMR, hello? Yeah.
Yes.
Sir, ICMR should include testing of surgical patients if the patient is going to be taken up for surgery in a hospital, because as per ICMR guidelines, the samples are not accepted by any virology center or even the private labs because that
you're right, as an elective thing they will not accept.
Cannot be. So that has to be included.
That has to be
as per the ICMR guidelines.
Correct.
And it should be escalated.
No, you're right.
So that is very important.
Okay.
Yes.
So thank you very much, all of you, and the
Thank you,
audience and Alkem for organizing. Thank you.
Thanks, sir. Thanks, Nitin, sir.
All the best.
Thank you.
Doctor, there are a lot of questions from the audience. Can we take them now?
Yes.
For how long we will take these questions, Yash? I think it's already 6:30.
Dr. Yash got disconnected, sir.
Sandeep, you have any comments on this? How long we take questions? Because
yeah, I believe there's a lot of excitement and there are a lot of questions from the audience. And we can compile those questions, and then we can personally send back the panelist responses.
Yes.
Yes,
good.
Yes, sir.
Maybe we can take maybe 2-3 questions with the, if panelists are okay, then we'll wind up, Sandeep, if that's okay.
I'm okay. I'm okay with that.
What about Yash and?
Yes, I'm here.
Yes, I'm here.
And Rajesh Mishra and Subal, if they are there, we'll take it. Otherwise, we'll close.
Yes, we will take it.
Doctors, you can see the questions in the Q&A box and chat box.
One question, Dr. Rangappa, you can start the discussion. You can read the questions.
So there's so many questions here. So
ones which have not been discussed.
I want to hear answer from, I don't know what question is, Doctor, someone has asked me this. So they said they want answers, but I'm not able to see the question he has for me.
The next one.
What do you recommend? What do you recommend on wearing face mask? That I think we have discussed elaborately, isn't it, Ash? We can move to the one.
I will still one point.
Yeah.
In community, start wearing a normal cloth mask. You will be 70% protected. Routine patient interaction, routine hospital visit, wear a surgical mask. High risk interactions, wear N95 mask. Very, very simple.
And prophylactic hydroxychloroquine in asymptomatic doctors and staff. What is your opinion?
High risk doctors who are immunocompromised, hypertensive, or like patients who are involved in air transport, air ambulance. Such people should probably take.
Yeah,
routinely you should not take.
Yeah, my subscription to that is anyone who is looking after a COVID patient and who wishes to be protected along with adequate PPE, they could consider.
One more point. Chloroquine is no magic bullet and it will not give you a safeguard. So PPE, and PP, this should be hammered.
Yeah. Do you want to care for patients in laminar flow theater or room, AC?
Laminar flow is better. AC is not good. If you can give a good ventilation, good enough. Otherwise, they should have a proper separate AHU. But it is not possible. So if you have an open ventilation, it is better. And WHO is also trying to work on that because most of our government hospitals or the facilities which government is taking, they have open windows. So it is a good idea to care for them in open rooms. It allows.
I think this question I can ask Dr. Bhaskar, who I see. Can we say that virus of Indian strain is mutated and has less virulence as per patient severity? Dr. Bhaskar?
I think, yes, probably we have coming across a lot of articles that the virus is mutating in different countries. So in India, there is a less virulent virus which has come in that we have seen, but we don't have any proof. We are working on that. All are working on that. So another thing is that we have a good racial immunity because we are suffering from lots of infectious diseases in our country. And we have a sort of immunity against those infectious diseases. So we'll be probably in a better equipped to counter COVID-19 also. So racial immunity and all those things are coming in. And also another thing is the summer has already set in, the higher temperature will and the dry environment will probably stop the transmission of virus from one person to another. Transmission that is from the raw the surface transmission.
I have a opposite view on this. Sorry for that. See, this virus is constantly mutating. This is the characteristic. So if it mutates further, we don't know. We cannot drop our guard. Why we have less mortality? Because we haven't been faced off with the virus. It has just started trickling. The mortality is not just dependent on the virus or the patient. It depends on our health resource utilization. The systems just crash. Patients die at home in Italy, in Spain. So if your words come true, nothing like it, but we have to we have to be very, very careful, and I will be
It's
very
very early to comment because this virus is only 4 months old. No, we are constantly scientists are studying it.
I wish your words come true, but
yeah,
there is one question: are we in stage 3? I think the hotspots have been identified. Their community transmission is occurring.
Yes.
And now there is no chance of already 14 days have passed after the international flight stopped. So there is no travel history is gone.
Yeah.
Now everything is contact, either contact stage 2 or stage 3. So I think we have already entered stage 3.
And another question to Dr. Bhaskar: can H1N1 positive patient also be positive for COVID?
Yes, there may be coexistence of 2 viruses that we are getting in BioFire panels. Also, we are getting 2 or 3 viruses. But BioFire so far it doesn't contain COVID, but we have seen that possibility of co-infection with 2 different viruses.
Can I add? There is a lot of co-infection. There is co-infection with influenza. There is co-infection with RSV, and as you. So if you have influenza positive or H1N1 positive, don't drop your guard again. It could be a super edit. It could be on TB. It could be on bacterial pneumonia.
Yes.
I think we'll take 2 more questions and wind it, Yash. This one is interesting. Should we consider therapeutic anticoagulation in patients with COVID-19 related refractory hypoxemic respiratory failure, given the fact that they can have microthrombi?
It should be personalized.
Yeah, I would say prophylaxis fast track still remains. So thromboprophylaxis definitely they will be on. So our hope and prayer is that would mitigate to some extent some microthrombi. I think we need more studies, because there is one study which has come out on heparin infusion which showed favorable benefit, but we need bigger studies to conclusively suggest that yes, it has a role.
It should be personalized and should be based on D-dimer or thromboelastograph, whatever we are comfortable with.
I think Rajesh Mishra wanted us to answer this ventilatory settings. This I covered in the talk. I think it is a standard ARDS ventilation if it is recruitable lungs. If it is non-recruitable, then be wary of good compliance. Then your therapy and your ventilatory settings, they don't need high PEEP. They may not need prone position. I think this is what Gattinoni paper showed us, that if they have a very compliant lung, then obviously these measures will not help. And if they have a non-recruitable lung, then proning will add modest benefit. And if you give high PEEP for a non-recruitable lung, the detrimental effects will outweigh the benefits. I think this is what we have understood, because there are 2 phenotypes of COVID that has been described. One phenotype is with low compliance, who would respond to your conventional ARDS net ventilation. The second phenotype is high compliant and a disproportionate shunt fraction, who do not respond well to your arts net ventilation. I think this is what we have understood at this. So you need to identify whether your patient belongs to type 1 phenotype where their compliance is low, or the type 2 where there is a perfusion abnormality. I think this is what we have understood at this point.
One more point, whatever mode you are comfortable with. See, this is no time to learn a new art, and many of non-critical care people will be ventilating these patients. So whatever mode you are comfortable with, they might require a moderate PEEP most of the time. If it is like conventional ARDS, you treat it like conventional ARDS. Otherwise, simple basic ventilation will do.
Yeah. Thank you very much, everyone. Sandeep, over to you. You can close the session, Sandeep.
Yeah, thanks a lot, Dr. Pradeep. Thanks, Dr. Yash. Thanks, Dr. Bhaskar, and thanks to all the delegates who has attended this program. It was too much exciting, and then it crosses the time limit. That simply shows the kind of energy and passion our medical fraternity is having towards the society and towards this pandemic. I'm really thankful, and then very soon we'll be getting back with the next topic, maybe in coming 10 days. Thanks a lot. Thank you.
Thanks, Dr. Bhaskar, sir.
Thank you.
Bye.
Bye.
Thank you, Dr. Bhaskar. Dr. Thank you.
आपको आशीष सर बुलाए
Sandeep sir, we can take all the questions, compile and email it to all the delegates.
Yeah, sure.
Yes, sir. Thank you, sir.
Thank you.